All right, let's jump right in and visualize some pediatric pathophysiology. Today, we're going to break down some really complex disorders into simple, step-by-step pathways. The whole goal here is to help you connect the symptoms you're seeing on the outside to what's actually happening on the inside, giving you a crystal clear mental flowchart that will really stick with you for your nursing exams.
So here's our game plan. We're going to start with something super common in peds, the whole cascade from a simple fever to serious dehydration. Then we'll pivot to a genetic pathway, PKU. After that, we are diving deep into the world of diabetes. We'll sort out type 1 from type 2, get a handle on hypo and hyperglycemia, and then trace that dangerous domino effect of DKA.
Okay, first up, let's tackle a cascade that every single pediatric nurse needs to know like the back of their hand. It all starts with something you'll see every day, a fever. So our cascade kicks off with a temperature of 100.4 degrees Fahrenheit or higher. Now, yeah, this is usually just the body's immune system doing its job. But, and you have to remember this for your exams, in an infant under 1 month old, any fever is a full-blown medical emergency, period.
So why is it that a simple fever can spiral into dehydration so quickly in a little one? Well, it really boils down to two big reasons. First, their little kidneys are still immature, so they're just not great at holding on to water. And second, a larger chunk of their body water is outside the cells, which means it gets lost way more easily. That's exactly why you've got to be hypervigilant about their fluid status. Now, understanding this progression is absolutely crucial for your assessments. Just watch how the signs evolve. Mild dehydration, it can be sneaky, but once you hit moderate, the signs get clearer. The baby's irritable, there are fewer tears, that soft spot on the head might be a little sunken, and cap refill slows down. By the time it's severe, the signs are screaming at you. No tears, sunken eyes, a deeply sunken fontanelle, and a cap refill taking longer than 4 seconds. These are the red flags that will pop up on your tests for sure. All right, let's switch gears. Our next pathway isn't started by an infection, but by a tiny error in the genetic code. Let's trace the domino effect of phenylketonuria, or as you'll see it, PKU. You know, at its heart, PKU is all about a broken metabolic process. The body is literally missing an enzyme it needs to break down an amino acid called phenylalanine. So when a child with PKU eats protein, that amino acid doesn't get processed. Instead, it just builds up and up in the blood until it becomes toxic. And that's where all the trouble starts. This right here visualizes the whole thing perfectly. It's a simple domino effect. First domino, the genetic problem means the enzyme is missing. That directly knocks over the second domino. Phenylalanine from food starts piling up in the blood. And that knocks over the third, most devastating domino. That toxic buildup starts causing progressive brain damage. See? It's a straight line from gene to symptom. So all that damage happening on the inside, it starts to show up on the outside in some really specific ways you'll be tested on. You hear about a musty odor in the urine? That's a classic sign of all that unprocessed phenylalanine. The seizures, the hyperactivity, those are direct results of the damage happening to the central nervous system. So how in the world do we stop this cascade? We have to go right back to the source, what the child is eating. The treatment is a lifelong, super strict diet that limits phenylalanine. This means you'll be teaching families to avoid all high-protein foods. We're talking meat, dairy, the works. And to become expert label readers, because that artificial sweetener aspartame has it too. Next up, let's look at a cascade that is, unfortunately, becoming way too common in kids these days. The path from obesity to type 2 diabetes. Okay, let's get this straight because it's a huge point of confusion. With type 1, it's an autoimmune attack that just wipes out the cells that make insulin. This leads to an absolute lack of insulin. It's just gone. With type 2, the body cells start ignoring insulin. They become resistant, and eventually the pancreas just can't keep up. And here's the #1 takeaway for peds. The biggest risk factor for type 2 in a kid is being overweight. So if type 2 is all about resistance, type 1 is about complete absence. Let's really drill down on the pathophysiology here. It's an autoimmune process that results in a totally missing key. So let's really think about this for a second. Insulin is the key that unlocks our cells so glucose can get inside and be used for energy. So what on earth happens inside the body when that key is just gone? Well, without that key, the body starts sending out some serious distress signals. And these are the classic 3 Ps you have to know. First, polyuria. The kidneys go into overdrive trying to pee out all the extra sugar.
All that peeing leads to polydipsia, this intense, crazy thirst from dehydration. And finally, polyphagia. The cells are literally starving, so they're sending desperate hunger signals to the brain. This starvation mode also explains the crazy fatigue and weight loss.
Now, if that cellular starvation keeps going, maybe because type 1 isn't diagnosed yet or it's just not managed well, it triggers a life-threatening chain reaction, diabetic ketoacidosis, or DKA. This flowchart shows the whole terrifying domino effect. Look, it starts with no insulin. That means glucose is trapped in the blood, causing hyperglycemia, so the cells start to starve. The body panics, and in a desperate search for fuel, it starts breaking down fat like crazy. The waste product of all this emergency fat burning is something called ketones, and they are super acidic. As ketones flood the blood, the whole body's pH drops and it's pushed into metabolic acidosis. And here are the hard numbers you absolutely have to memorize for your exams. DKA is defined by this triad of symptoms: a blood glucose over 300, ketones showing up in the blood and the urine, and metabolic acidosis. This is a true medical emergency. Okay, now that we understand the absolute extreme of DKA, let's pull back and put the two biggest daily challenges side by side, dealing with low versus high blood sugar. This chart right here is pure gold for exams. On the left, you got hypoglycemia, or low blood sugar. Think anything below 70. This causes neurologic signs: sweating, shakiness, confusion. On the right, hyperglycemia, or high blood sugar, over 200. This brings back those 3 Ps, and if it gets bad enough, you'll smell that classic fruity breath from the ketones. The causes and symptoms are literally polar opposites.
So when someone's hypoglycemic, you have to act, and you have to act fast. The goal is to hit them with a rapid-acting, simple carbohydrate to stop that downward spiral. We're not looking for a granola bar here. We need sugar that gets absorbed instantly. The rule of thumb is 15 grams of carbs. Think half a cup of juice, a few hard candies, or some glucose tabs to get that blood sugar back up into a safe range, quickly. And to keep hyperglycemia from spiraling into DKA, especially when a child is sick, every nurse has to be able to teach the sick day rules. This is so important. You always give insulin, even if the child isn't eating much, because illness and stress actually make the body need more insulin. You have to check their glucose and ketones constantly and push fluids like crazy to help flush those ketones out.
So let's wrap it up with this thought. Pathophysiology isn't really about just memorizing a list of symptoms, is it? It's about understanding the story, the cascade, the dominoes falling one after another. It's about understanding the why. So now that you can visualize these pathways, how is that going to change the way you attack your next exam question?